All right, so maybe you saw my video on TikTok or maybe you just ran across our page on YouTube, but if you're a first responder, it is extremely important that you know how to work CPR. Traditionally, first responders, EMTs, paramedics, firefighters, we are the best at working a code. We are the best at working a CPR patient because we do it so often. So it's extremely important that we understand how to properly work a code. And the biggest thing that we have to know is about the slope of death and understanding that every minute that goes by that a patient is in cardiac arrest, their survival decreases by 10%. So the faster we can get to that patient's side and initiate chest compressions, the greater the chance of survival that patient has. So I know that, I work for a fire service and I know that sometimes people get a little bit complacent. But if you get a call for a CPR, you need to be running to your rigs, your trucks. You got to be getting on those things and you got to be getting en route. You've got to get to that patient's side as fast as possible, as fast as safely possible. You have to get to that patient's side. So there's a lot of things. If you dispatch, it all starts with dispatch. Actually, it starts before dispatch. The patient goes down. I talked about in another video about the importance of lay people knowing how to do CPR. If you're a lay person, a non-medical person, super important that you take a basic life-saving class, a CPR class, and learn how to do proper chest compressions. You do not know how to do breaths. We're doing hands-only CPR now, so it's simply doing good chest compressions and keeping the blood circulating, keeping the brain oxygenated. There's plenty of oxygen left in the blood as long as we move it. There is plenty of oxygen left in the blood for several minutes after a patient goes into cardiac arrest to keep their brain alive, but it has to be circulated. So that's the first thing. Second would be the dispatchers. And if you don't have a program in place now to communicate with your dispatchers, the importance of knowing when to have somebody start chest compressions, knowing basically they're just checking for responsiveness. We're not checking for pulses. We're not checking to see if they're breathing. We are checking responsiveness. And if the patient isn't responding, basically you're starting chest compressions. But if you don't have a program in place to work with your dispatchers and educate them on how to communicate this to people that are calling in, that's a very, very important step, a huge step in increasing survivability in these patients. Another thing is tones. In my department, we changed our tones. So we have a specific tone. If it's a cardiac arrest, we have a specific tone so that the second that tone goes off, we know, okay, this isn't just a fall patient. This isn't just a run-of-the-mill medical call. This is a cardiac arrest. And so that automatically, hopefully, encourages people to get out to the trucks faster and get en route faster. So getting on scene. This is another big thing. If you're on an ambulance and you arrive on the scene of a potential cardiac arrest, most of the time, what have we done? I've been in the fire service for nearly 20 years, and for 18 and a half of those nearly 20 years, we would get on the scene of a cardiac arrest. We would get out of the ambulance. We would walk to the back, maybe jump in the back. We'd grab our Lucas device. We'd grab our suction, whatever you think you need, and you pile it all onto the cot, right? Then you pull your cot out, and then you walk in. That is precious time that is wasted, and your patient is literally dying. Their chances of survival are significantly decreasing because you're gathering all of your equipment. So let me pose this to you, another way to think about responding to a CPR, whether you work private ambulance or you work for a fire department. So let's say you work private ambulance. And you respond with a fire agency with you. So communicate and train. That's the number one thing you can do with this topic is communicate and train with your fire department on how you're going to do this. If you're a private ambulance or if you work for a fire department and you're on the ambulance and you arrive on scene first, what I would suggest is send one person. And again, this is considering the scene is safe. I'm certainly not suggesting that anybody puts their own safety at risk. This is considering that all things are safe. It's safe for you to go in the house. But one person goes into the house and gets to the patient's side, okay? They don't have to have anything with them, right? There's two things that they want to do. One, the most important thing is verify, is this patient actually in cardiac arrest? Okay, and if they are in cardiac arrest, we are going to initiate chest compressions. Okay, we've got to get on the chest as fast as possible. Now, the partner or the other person on the ambulance, your job is to grab the monitor. Now, you can grab the monitor or your EMS bag, whatever kind of bag you carry. That's fine if you want to bring in both things, but at least bring in your monitor. Okay, go in, and that first person that's made patient contact, they verified the patient is in cardiac arrest, they have begun chest compressions. You come in with the monitor. Next, you want to get the patient hooked up on the pads, okay? And then you want to see what rhythm they are in. Is it a shockable rhythm? Is it not a shockable rhythm? If it's a shockable rhythm, obviously you're going to defibrillate and get right back on that chest. And then you're going to be rotating rescuers. That's really all you need to do for the first several minutes of a CPR, is make sure that you're doing good chest compressions and defibrillating the patient as possible. If you're on the fire truck and you're responding behind that ambulance, you show up, and because you've communicated this and you've trained over this, you know that your crew is inside and they probably only have their monitor and maybe their bag. So you're going to have to go now to the med unit. You're going to grab the cot, you're going to grab the suction, you're going to grab the Lucas device or whatever equipment that your department or agency uses, and now you're going to bring all that stuff in. We do not need to have the EMS cot in the room on a cardiac arrest within the first 10 minutes. We just don't need it. The data shows over and over again that if we as first responders do not get ROSC on a patient, the possibility of getting ROSC on that patient and them walking out of the hospital neurologically intact is next to nothing. Okay? We are the best chance of that patient's survivability. And if we're rushing trying to get to the cot and get out to the ambulance and chest compressions aren't being done properly, or we're not ventilating our patient properly, or maybe not giving medications properly, number one thing being chest compressions, we are doing a disservice to our patients, right? So we need to slow down. We need to focus on those good chest compressions. We need to be swapping out rescuers, get them on a Lucas device when it's appropriate, and being able to deploy that very, very quickly, right? We need to get IV access, control an airway, whether that's if you're an EMT, whether you're an OPA, NPA using a BVM, or maybe a supraglottic airway, or if you are a paramedic and you have the ability to intubate and secure an airway on your patient. But we should not be in a rush. And before you even think about going to the ambulance, you should have some sort of a compression device in place if you have those. If not, you have a way to be continuing compressions while you're moving your patient out to the ambulance. You should have some sort of IV or IO access on your patient so you can give medications, and you should have some way of ventilating your patient. Again, if you're an BLS only crew, you have an OPA, NPA, or both, and you're bagging your patient, or if you can, a supraglottic airway, or if you're a paramedic, you have a supraglottic airway or a ET tube in place. You should not think about moving your patient until you have all those things done. Once all those things are done, get them on the cot, get them out to the ambulance, and now you're basically just letting the compression device do its thing. You're pushing meds and you're ventilating, watching for ROSC, end tidal rises, things of that nature. So we really, again, need to think about these things. We need to train over these things. The Seattle Fire Department Resuscitation Academy is a phenomenal thing that really teaches first responders how to be really good at working a code, because, again, we are the patient's best chance of survival.